Hello everyone, in this video we will discuss about upper GI bleed. Anatomically, upper and lower GI is divided by ligament of trees. This is the second part of duodenum, third part and fourth part. This is the duodenojejunal flexure. If the bleeding occurs above this part, it's called upper GI. If occurs below it, it's called lower GI bleed. For example, a patient came to your emergency department saying, I coughed up what it looked like barbecue sauce, but I haven't eaten it. This means it could have the coffee color vomit, which could be due to the upper GI bleed. If we suspect, then we should see the sign like hematemesis, vomiting of blood, coffee ground of vomitus, melena means passage of black tarry stool, and it will check for hemodynamically instability like increase in the heart rate, decrease in the systolic BP, and altered mental sensorium. We should go for ABC resuscitations, airway. We should secure the airway if the patient is altered with altered sensorium, or if the patient has profuse bleeding. We should go for the breathing. We should give supplement oxygen if the saturation is less than 82% in the room air. We should check the circulations. We should check the BP and heart rate. If the BP is less than 90 systolic BP, or the heart rate more than 100, then we should see for the look for sign of shock, and we should immediately resuscitate the patients. We can resuscitate using NS or RL 500 ml to 1 liter bolus. We should transfuse blood if the hemoglobin is less than 7, or hemoglobin less than 7 in case of cardiac patient. We should do Foley's catheterizations to monitor the urine output of the patient. It should be more than or equals to 0.5 ml per kg per hour. We should continue monitor the patient. We should check the cardiac. We should check the cardiac oxygen sat and BP. We should check. Now we have to send some live investigations: CBC, PTNR, APTT, LFT, RFT, electrolytes, blood grouping, screening, cross matching with more than 2 units of PRBC, ABG if the patient is unstable, ECG especially in case of elderly cardiac history patients. We should give the pharmacological therapy of pantoprazole 80 mg bolus with antibiotics like ceftriaxone, broad spectrum antibiotics. We can give the maintenance fluid of pantoprazole like 8 mg per hour in infusions. If, for example, if you mix 2 ampoules of the pantoprazole which contains 80 mg, we can mix it with the 50 ml NS and transfuse at the rate of 5 ml per hour rate. If we suspect varices, then we should give octreotide. The dose is 50 mcg IV bolus followed by the 50 mcg per hour for 3 to 4 days. We should keep the patient's NPO, nothing per oral. We should stop NSAID, anticoagulants, antiplatelets unless it is life-saving. We should triage the patients by seeing the Glasgow Blatchford score and Rockwell score. If the GBS Glasgow Blatchford score is 0, then we can send patient from outpatient. If it is more than 1 or 1, we should do workup. Now let's see the Glasgow Blatchford score. It has the components like hemoglobin, blood urea nitrogens, systolic BP, and other markers like pulse, melena, syncope, hepatic disease, and cardiac disease. If the blood urea nitrogen is less than 6.0, then it's called 0. If hemoglobin is less than 13 in case of men and less than 12 in case of women, it is 0. If the systolic BP is less than 100, then if it is more than 100, if systolic BP is more than 100, then it's 0. Other markers like if the pulse is less than 100, it's 0. More than 100, 1. Melena if present 1. Syncope if present 2. Hepatic disease 2. Cardiac failure 2. Now let's see the Rockall scoring system. It is used for predicting the rebleed or the mortality. It has components like age, shock, comorbidities, and endoscopic finding like source of bleeding and stigmata of the recent bleeding. Age less than 60, 0, more than 80, 1. Comorbidities like congestive heart failure, ischemic heart disease, 2. Renal failure, liver failure, metastatic disease like cancers, then 3. If there is no shock, then 0. Pulse more than 100, 1. BPA less than 100, 2. Source of bleeding like malarious tear, 0. And other peptic ulcer diseases, then 1. If malignancy, then 2. Stigmata of the recent bleeding, if known, then 0. If there is presence of adrenal clot spurting vessels, then it's 2. If it is 2 or less, then low risk of rebleeding. If it is 3 or more, there's increased risk. We should admit and do close monitoring. If it is 6 or more, there is higher risk of death. We should do counseling to the patient party. Now we should do endoscopy if it is within 12 hours in case of emergency, or within 24 hours in case of other conditions. We should check the GBS. If GBS is more than 12 or more, then we should go for clippings, epinephrine injections, thermal coagulations. If it is varices, then we should go for band ligation or sclerotherapy. We should do second endoscopy, second look endoscopy if IRIX or rebleeding, and we should infuse PPI for 72 hours, then oral for BD for 4 to 8 weeks. If it is varicose bleed, we should give for octreotide for 3 to 5 days. We can start for propanolol after, when the patient is stable. We should monitor BP, heart rate, hemoglobin 6 to 8 hourly, and we should check the causes and treat. And we should do for secondary preventions. We can go for Aspergillus eradication in case of peptic ulcer disease. Should stop NSAID, switch to COX-2 inhibitors if necessary. If anticoagulation is essential, restart when the patient is stable with GI input. We can do discharge and long-term strategy. We should go for GI follow-up within 1 to 2 weeks. We should educate the patient regarding red flag signs and complication of the medications. We should provide the discharge meds, oral PPI, and iron supplementations. IRIX patients are considered prophylactical banding for varices. Thank you.